The following podcast is part of a certified educational activity titled The New Normal: Digital Technologies for People Living with Insulin-Treated Type 2 Diabetes. Access the entire activity and complete the post-test at peerview.com/UHT860. Downloadable slides and practice aids are also available.
Hello, my name is Earl Hirsch from the University of Washington in Seattle. Welcome to this educational activity on advances in diabetes technology for people with type 2 diabetes. This will be a general overview of a lot of information because there has been so much that has happened over the past 10 years, even 5 years. And this overview will give you an idea of some of the things that have happened, and you can use this information to look more closely at some of this technology we will be discussing today. Our goals for today are to augment your knowledge about the latest advances in connected diabetes technology for patients with insulin-treated type 2 diabetes and equip you with the skills you need to teach patients how to use diabetes technology to overcome common barriers to insulin initiation, delivery, and dosing. So what we're really doing here is keeping up with the time. Advances in diabetes technology are for people with type 2 diabetes too. Many of us have been working with technology literally for 25 years, mostly focused on type 1 diabetes. But that's not true anymore, given how far the technology has come, given all the evidence we have. Now, let's talk about insulin for a moment. Many people find insulin not a very important or sexy thing to talk about, but actually in type 2 diabetes, insulin continues to be quite necessary, especially in people with severe hyperglycemia, which we see in type 2 diabetes where they are so insulin deficient, they are losing weight, they are catabolic, they're getting up at night to urinate, and they have double-digit hemoglobin A1Cs. In addition, we use it for comorbid diseases, limiting the use of other glucose medications. This happens quite a bit. Few or no functioning beta cells. And we see this now, but the prediction is we are going to see this even more in the future, given the explosion of type 2 diabetes we see with adolescents. And as it turns out, we now understand that the beta cell lesion in that population of young people is much more severe than what was seen in their parents and their grandparents. And the issue of literacy and healthcare numeracy needed for insulin therapy. And the question is this still the case? To calculate doses, to administer the insulin aseptically, and to adjust insulin based on insulin type, weight, glucose patterns, meal composition, illness. There are just so many other things that dictate how much insulin is needed. And can the average patient we see do this? So what we really need to do is to simplify insulin treatment for our patients with type 2 diabetes. This is a fascinating slide. To me, it's fascinating looking at how insulin has changed over the years. We can start with insulin aspart here at this green bar going from 2016 to 2020. And you can see that the aspart over the years has gone down a little bit, but it's been mostly the same, but certainly from 2016 to 2020, it's gone down. Insulin degludec, which is, in my opinion, the best of the basal insulins, it only came out shortly after 2016, so it's not surprising that it's gone up. The next lighter green bar is insulin detamir, and this is really interesting because insulin detamir went down as insulin degludec went up, but here we are in 2024, and earlier this year, at least in the United States, insulin detamir was removed from the U.S. market. The biggest one here is glargine, which was introduced in the United States in 2001. And there's this slight reduction of glargine as we have these ultra-long basal insulins like degludec, which I find so interesting. Now, the one next to glargine is glulisine. It's very rarely used as a rapid-acting analog. And the one after glulisine is Lispro, which was our first insulin analog. And Lispro has gone down a little bit over the years, not a huge amount. It's the one after Lispro that to me is the most interesting. NPH insulin. NPH insulin, which we've had in the United States since 1950, what we see over the years is NPH over the years has gone down. And in fact, if we look at NPH in 2020, the last year we have, you barely see it. The other one I want to point out is that we're using less of the premixed insulins over the years and regular insulin. Regular insulin, it's not gone away, but it's very, very low. It's low and stable. And as it turns out, we still use a lot of regular insulin. And where we use it is in the hospital with intravenous insulin. But nevertheless, this is what's happened with insulin over the years. And we're talking about 8 million people here in the United States who are receiving insulin therapy. We can also look at insulin by the complexity of the insulin, whether you're giving it once a day with basal insulin, or we're giving insulin 4 times a day where you take insulin with each meal right here, or we can give insulin continuously with pumps. And you may ask, why are we talking about pumps if we're talking about type 2 diabetes? Well, as you'll see in a few minutes, we are starting to use more pumps with type 2, and the prediction is over the next few years, we will be using a lot more. The evolution of insulin therapy and really the evolution of diabetes technology, going back to the 1920s with this original insulin vial that we saw in the 1920s. And it brings to mind the first time I personally saw a continuous glucose monitor was at an American Diabetes Association meeting in January of 1999. It was very primitive to what we have today, but the world has certainly progressed since then. But as it turns out, today in 2024, we have 4 FDA-approved automated insulin delivery systems where the sensor tells the pump how much insulin to give with modulating the basal insulin. So when we look at insulin delivery technology and the evolution over the years, in the past, we used vials and syringes. We used home blood glucose meters. Before that, we did urine glucose testing. That's all we had. And we used paper logs to track what was happening with the blood sugars. We don't do that anymore. Now, we, for the most part, use smart insulin pens. We use patch pumps. We use continuous glucose monitoring. Everything goes into your smartphone app, so you can look at the data that way, and then you can share the data with you, the provider, by taking that data from the app and putting it into graphs and into ambulatory glucose profiles and to metrics that we can really help our patients. So when we look at diabetes management ecosystem in the overview, we're going to start with blood glucose monitoring, because glucose monitoring allows us to look at glycemic variability, the fluctuation of blood glucose that occur in response to diet, exercise, medications, or pathologic processes. Furthermore, monitoring the glucose allows patients to identify when glucose levels are too high or too low, and then they can adjust insulin or they can take in carbohydrate accordingly for hypoglycemia. And, if I think about what I've seen in my career, starting with the urine glucose, then moving to the fingerstick glucose, and now the CGM, for patients who are engaged with their diabetes, they certainly have the opportunity to fine-tune the insulin or fine-tune the carbohydrate to keep the glucose levels in target. And to that point, these are data that were just presented in September of this year and published at the same time. And these are data that Dr. Garg, Dr. Bergenstahl, and I reviewed, looking at a very large data set in 3 different groups of people. We are looking at this data set in NIT patients, that is no insulin therapy, BIT patients, basal insulin therapy, and PIT patients, patients with prandial insulin therapy. And what you can see is that when the continuous glucose monitor, whichever one was used, we don't even know which ones were used, no matter if they were on basal insulin, prandial insulin, or no insulin, the hemoglobin A1C levels came down, and they came down quite a bit. And the surprising thing to some people, not to me, is that even for people not taking insulin therapy, by just changing lifestyle, changing the Coke to water or to Diet Coke or to non-sweetened tea, or taking that extra walk when you see that glucose level spike after dinner, the A1Cs in these patients not on insulin came down quite a bit. And maybe even more importantly, we saw a reduction in all-cause hospitalizations. And all of these were statistically significant compared to the 6-month pre-index. Whether it was no insulin therapy, basal insulin therapy, or prandial insulin therapy, there was this reduction at 6 months and then again at 6 to 12 months, all-cause hospitalizations. There's a lot more data in this paper if you are interested, but even though this is an observational big data type of trial, this is not the only trial to give these same associations. And so if we look at the proposed routine use of CGM throughout the natural history, we look at what happens at diagnosis, that is, the short-term use to assess response to diet, exercise, CGM, and treatment plan, and prevent, manage hypoglycemia in those patients starting directly on insulin. Now, I will tell you that many of us, even for patients with type 2 diabetes, not on insulin, but especially those who go on insulin, we want to see the CGM at the very beginning, partly due to what I showed you a moment ago in the previous slide. But the other reason is we can see discordance in A1C. We can see where the A1C does not match up directly with the blood sugars. And by using a CGM, even once, right when somebody is diagnosed, you can see if that A1C is discordant or not. And that's very helpful for following the patient further on. You can management of stable disease. Again, using the CGM in conjunction with the A1C, we can use these tools to predict complications and ongoing use of the CGM to adjust insulin therapy as needed. And I should point out, there are some patients, especially patients who are put on GLP-1 receptor agonists, where we can reduce the insulin therapy or occasionally even stop the insulin therapy, or at least some of the insulin therapy. Maybe it's a meal you can stop it. Maybe you can stop most of the prandial insulin, but you really can tell by the CGM much better than you can by an A1C, which is just a crude way to look at the average glucose. And then, of course, with longer disease, these patients become more insulin deficient. Hypoglycemia becomes a bigger problem, especially in our elderly patients. And it's important to look at the glucose in our elderly in particular to avoid the hypoglycemia. So we now have really two different types of CGM technologies. The intermittently scanned CGM, which was the original Freestyle Libre and Libre 2, where the readings are taken every 5 to 15 minutes and then stored, and then the readings are displayed, but everything else is real time. And here the readings are taken depending on the sensor every 1 to 5 minutes. They are then displayed as they are required on a smartphone app or on a reader. Some people, especially, in my experience, our elderly patients prefer the readers than using the smartphone, or these continuous CGMs can integrate with a pump or a connected pen. Both of these technologies provide significant reductions in A1C. I just showed you an example of that in our retrospective study, with no adverse impact on hypoglycemia relative to fingerstick glucose testing. And I need to point out that this is not just retrospective big data studies like I've shown you. With basal bolus insulin in type 2 diabetes and basal insulin alone, this has been shown in properly controlled, randomized controlled trial. The most commonly reported adverse effects are sensor site related, and taking this even a bit further, some patients have allergies to the tape or the adhesive, and that seems to be the biggest problem we see. The bad news about that is that a manufacturer may change the adhesive and not tell anybody, and now all of a sudden somebody is allergic. It's not common, but we do see it. The good side of that is when they change the adhesive, now somebody who was allergic may do fine. And these are things we see in our clinic every day. So the two most commonly used sensors we use are the Freestyle Libre 2 and 3 and the G6 and G7. We're now pretty much all moved to the G7. The Libre 3 is continuous real-time monitoring, every minute data. It's approved for people over the age of 4 with either type 1 or type 2 diabetes. It's compatible with all of the technology you would want. It uses an extremely small sensor the size of a penny. It lasts 14 days. And as I mentioned, the Libre 2 uses an intermittent scan. It stores it for 8 hours. And here the age goes down to 2 years with either type 1 or type 2 diabetes. Now, note that the range of glucose with the Libre is 40 to 400. It's the same with the G7. And I point point that out because in a moment you're going to see that the sensors have different ranges. But for these sensors, it's 40 to 400. The G7 is also real-time data every 5 minutes instead of every one. Like the Libre 2, it goes down to 2 years of age. This one lasts 10 days. The Libre lasts 14 days. It's again compatible with all the technology. And I just want to point out, without going through all the details, but both of these sensors, I should say, will be compatible with multiple pumps within the next year. And so patients will be able to choose which of their sensors they want to use with their pumps. Now, the reason why I talked about the ranges of glucose is that at the very beginning of September 2024, we were introduced to 2 over-the-counter CGMs. One is called the Stelo. It's for people who have type 2 diabetes who are not on insulin. This was approved by the FDA, but one does not need a prescription for this, so it should be much easier to get. It logs data every 15 minutes. The sensor lasts 15 days. So this is very different than the G7, which lasted 10 days. This lasts 15 days. And notice, for these people not on insulin, the range is 70 to 250. At least not on insulin with type 2 diabetes is the intended group approved by the FDA. The Lingo has also come out in early September. Now, this is different. This is for people without diabetes. There are like 90 plus million people in the United States with prediabetes. So this would be a great sensor for that population. It would be a great sensor for people who don't even have prediabetes, but they have risk for it, and they want to look at how their lifestyle impacts their blood sugars. So this is a great sensor for them. It logs data every minute. It lasts for 2 weeks. And it works right now only with an iPhone 11 or later iPhones. But note this sensor. It goes from 55 to 200. And the reason is these are supposedly people without diabetes. And then finally, later in 2024, we're going to get the Rio. And the Rio indication is more like the Stelo for people with type 2 diabetes who don't take insulin, and it's a 14-day sensor. This is a lot to keep up with, but this is what's happening. And this is related to the explosion of sensors we're seeing that every provider will see in their office. And the other point I want to make about people wearing sensors, whether they're on insulin or not, whether they even have diabetes or not, is that these people come into the hospital. And then what do you do with the sensors? Does your hospital have a policy on how to deal with sensor glucose with the understanding patients are wearing these sensors, yet the sensors right now, and this may change next year, but right now these sensors are not FDA approved to be used in the hospital. So it's something to think about. The Eversense sensor, very recently, the Eversense sensor was approved for 365 days, and it's a sensor that is implanted under the skin, soon coming for 365 days. The one available now is 6 months. We did have a 3-month sensor. It can be done in the physician's office. There is this transmitter that you see here that is removable, and I wish I would have had this a few years ago. I'm in Seattle. I've had some professional athletes, Seahawks, Mariners, and also women's softball on the University of Washington Huskies. I wish we would have had this for these athletes. We didn't have it in those years, but I can think of a lot of patients who would prefer to have something like this, especially with sensors when they fall off or knocked off frequently. Okay, so we talked about glucose monitoring. Let's move on to insulin delivery as we look at technology with insulin delivery, because devices such as pumps or pens are used to inject measured doses of insulin through the skin and into the fatty tissue below. I just want to point out that there is another device that I'm just going to mention it now, and it's an inhaler for a study that we just completed looking at pulmonary inhaled insulin. And we're not going to talk about it, but pulmonary inhaled insulin is not new. It's actually been around for 10 years, and the trade name for that is Afrezza. Now, let's start looking at these smart insulin pen caps, and there are a few that have been FDA approved. First is the Bigfoot Unity. It works with the Libre 2, and it's available in limited markets. We use a lot of the InPen in our clinic, and as a matter of fact, I would say probably the majority of patients who are on multiple injections use this InPen system, and it's been fabulous because, number one, from the patient perspective, the data has clearly shown with the InPen that we see a reduced number of missed doses and misty-med insulin doses, that is looking at doses that are the right doses given, but it's given late. And that has improved. We have seen improved time and ranges on the CGM. And in one study of over 5,100 patients, 552 of whom had type 2 diabetes, we saw these improved outcomes. This was also shown in a study of 88 low-income people with type 2 diabetes. And I need to point out, from the patient perspective, they can also see how much insulin is on board, so they don't have to stack the insulin, leading to hypoglycemia. The insulin pen has a bolus calculator on the app, and so patients, if they want to, can calculate their insulin and not stack it that way. And maybe most importantly, when physicians look at the downloads of this, they can really understand what the patients are doing, if the prandial dosing is correct, the timing of the dosing, and it's really a wonderful teaching tool that the physicians can use with their patients. Now, as it turns out, there are other pens. The Tempo pen came out in early 2023, I believe. It has many of the similar features that I described with the InPen. And again, what is so helpful are the downloads that these pens give. Now, the Novo Pen Echo is available in the US. It uses a cartridge instead of a disposable pen. It has a memory function. It communicates to a smart device via near-field communication, but the much more sophisticated Novo Pen 6s and Novo Pen Echo Plus are available in Europe, not in the United States, at least not now. Hopefully, we will get these more sophisticated Novo Smart Pens into the US in the future. So when we look at smart insulin pens incorporating various degrees of interconnectedness, I love that word. We look at the legacy insulin delivery, vial, syringe, traditional insulin pen, no way to track unless you do it on pen and paper. But then we move all the way to stage 4 and 5, where we have smart insulin pens with dose calculators, like I was just talking about with the InPen. But this is going to get even more sophisticated, where we're going to use these smart insulin pens with advanced decision support. So the pen technology will make suggestions about what to do when that trend is going up, what to do for a pizza, what to do if you know you're going to be exercising, playing tennis or basketball 2 hours from now. These pens are going to get smarter. Right now, we are just seeing the very tip of the iceberg. So, who is most likely to benefit from this connected diabetes technology? Well, these authors think, and I agree, patients with very high A1Cs, above 9%, who are initiating basal insulin, who are the most likely to benefit from these connected pens when used in combination with self-management, support with educators, and patient education. Other patients who are likely to benefit from these connected pen systems include patients with poor adherence to treatment, because seeing that the dose is missed, having a CGM where you get an alarm go off when the blood sugar is high because you missed a dose, these are really powerful tools. Patients with difficulty adjusting treatment, that is, performing calculations. What these smart pens can do is, instead of doing carb counting, you can just say small, medium, and large carbohydrate meal, and then it does the calculations from that with the blood sugar. Very powerful. Patients who prefer integrating data from all of their devices. So you can get your pump if you're wearing a pump, your sensor if you're wearing a sensor, and you can put it onto your app on your smartphone or your iPad. Patient whose insulin management is overseen by a caregiver. Now, this is really important. In our clinic, we are having an explosion, and this is a good thing, of type 1 diabetes in the elderly. But we also see the type 2 diabetes in the elderly, where insulin management becomes more difficult. And what this technology does is it allows the caregiver to see if the patient, often the spouse, has actually given the insulin, because you have it all tracked on the app on the phone. Very helpful. Clinicians need to commit to ongoing training as new advances in sensors and apps and other system components are made. And this is true whether you're a primary care physician or an endocrinologist. This is all changing so quickly, and I think a good piece of advice is to find a technology enthusiast on your staff, because if there's somebody who's really into it, maybe they have a personal connection to diabetes. We had somebody in our clinic who had a very young son with diabetes who just took over our technology, and this was during the pandemic, and it was really great because she understood it and she was so passionate about it. So if you have an enthusiast on your staff, that is wonderful. What about the patient perspectives of this connected diabetes technology? Well, a systematic literature review showed that high patient satisfaction with connected insulin pen systems. Now, I have to point out, not every single patient loves their pen system, but as a rule of thumb, this has been by far our experience here at the University of Washington. Patients especially appreciated the ease of use of these systems and being able to upload and share data. And this is true that you don't need a huge training. You need a little bit of training, and obviously some patients will need more than others, but it's not like starting an insulin pump on somebody who's never been on an insulin pump. Not like that at all. Alert functions and simple and clear data presentations were praised. The systems reduced missed insulin doses, as I mentioned, reduced suboptimal dosing, improved various measures of glycemic control, including A1C and time in range. And these insulin pen systems may be cost savings, especially if you have better blood sugar control. My editorial comment is, at least in our clinic, we have really latched on to these connected pen systems. We find them fantastic. But with that being said, as a rule in the US, these are not as popular as they are in Europe. Now, what about preferable characteristics of pump therapy in people with type 2 diabetes? Well, if you have pump therapy, most patients prefer no tubing with a patch pump. Not everybody that's important for. You need to ideally have at least some basal rate profile, this background insulin, one standard bolus with predefined bolus. You want to have an insulin reservoir that holds enough insulin. Ideally, you would like to use any concentration of insulin on the market. Now, unfortunately, this is not the case from the US FDA. Right now, from an FDA-approved point of view, you can only use the U100 insulin. And that's not to say people don't use other concentrations of insulin. And then again, like we talked about, CGM connectivity and sharing the care with the providers. So keep in mind, this is a heterogeneous disease. People have different needs. People have different wants in terms of what works best for them. And those with poorly controlled diabetes, the use of a pump is probably more effective than MDI therapy. We're getting more data about this, and more data will be coming in 2025. As we know, there are other companies looking at this data in type 2 diabetes. Right now, we have the data with the Omnipod 5 pump in type 2 diabetes. That pump was FDA approved, but we're going to be seeing the same thing with other pumps, I predict, in the future. You want to have in this population pump features and handling really geared for people with type 2 diabetes. Easy is good, and the RCTs are needed to assess whether patch pumps specifically designed for type 2 diabetes are more effective than other intensified regimens. And as I noted, the Omnipod 5 randomized controlled trial was presented, and indeed, the data looked very good. Now, there are some other sort of, I don't want to call them pseudo pumps, but there's other technologies patients may want. For example, Simplicity is a patch which is tubeless and it's mechanical. There's nothing here pushing it in. There's no electronics here. The needle is inserted effortlessly. It's hidden. It only uses rapid-acting analogs. It only gives mealtime insulin. And many patients use this going through their shirt or their blouse. It holds up to 4 days of bolus insulin. There's no data management software, at least not at this time. And you can see that the patient just presses the buttons here to give the 2-unit bolus of insulin. We've had the Vigo for a long time. The Vigo is a disposable tubeless mechanical device. Again, hidden needle insertion. It uses U100 rapid-acting analog, supports basal plus, which is one injection of prandial insulin and MDI regimens. It holds 1 day of one of 3 different basal doses. You can get 20 units a day, 30 units a day, or 40 units a day. And again, it does this by this mechanical delivery of giving 20, 30, or 40 units over 24 hours. And like the previous one, it doesn't have any data management software. Where the technology has moved in type 1 diabetes and now moving in type 2 diabetes is with automated insulin delivery, where you have a sensor. The sensor then goes to an algorithm in a pump. There is software in the pump that will then modulate the basal insulin. And in fact, it can give mini boluses depending on which pump. It can give automated boluses every hour depending on the pump, but they all modulate the basal. So even if a bolus dose was missed or not enough insulin was given, it will give additional insulin to bring the glucose in range. By the same token, if there's too much insulin, too much exercise, it can slow the insulin down and even suspend the insulin to get more time in range. This is the Omnipod 5 that I mentioned. We actually have the data on this. It now integrates with the G6 and G7. It integrates with Gluco, which is the software company that allows us to look at the data. There's 24/7 support, the training sessions from some very helpful trainers. If you don't have the nursing education support in your clinic, you don't have to have that for onboarding patients onto Omnipod 5. Support groups are available, and patients do have the opportunity to do free trials. The other thing I want to point out about this is that getting the pump, prescribing it, and also from the patient's perspective, it's generally been quite easy for commercial patients because it is a pharmacy benefit, and that makes life much, much easier. And this has been used in type 2 diabetes now since the pump came out, the Omnipod 5. But what I will tell you is with the recent approval by the FDA, I think we're going to be seeing much more usage of this pump around the United States. Now, there are going to be other pumps come out. Now, what about smartphone apps? These are just three. There are others, but these are the three most common ones that are used. There's My Sugar, which is a logbook and it's a bolus calculator, and it shares all data by downloading and printing. It can be used by either the iOS or Android, and there actually is a free pro version. We all use Clarity and we use the Freestyle Libre Link. And these are both very powerful diabetes management softwares, and they greatly help our patients, both when we are helping them in the clinic, but they look at them on their own. I am convinced when these patients look at their data on a weekly basis and they can very easily see that their blood sugars are high after dinner, even though they're giving their insulin, but they didn't really pay attention to it in real time, they can make adjustments on their own, and they often do. So we have this connected ecosystem where we have the smart pen, we have the sensor, we have everything now talking to the phone. And the phone is really becoming the nucleus of the diabetes system, where we are going to be seeing more and more support algorithms where the phone, the brains of this is telling the patient what to do with insulin and maybe also what to do with carbohydrate if glucose appears to be getting low. What about data sharing between patients and healthcare professionals? Well, there's a lot to be said. There are advantages and disadvantages of doing it continuously, where you can look at this whenever you want to as a healthcare professional. On demand, where you can look at it, you get a call that somebody is sick, maybe somebody has the flu, maybe they're not sure what to do as they prepare for their colonoscopy, but then you have to deal with all the passwords and the different accounts. Selectively, the patient decides who can see the data and when, but then not everybody can see it if there's an emergency. And then what we started in our clinic in 1995, the patient comes in and then we just print the data we get from the meter. We don't do this pretty much anymore. We want people to be connected in some way, if at all possible. It's been a long discussion about integrating all of this with the electronic healthcare systems. Rich Bergenstahl was the first to do this, to my knowledge, with the Libre system, but it's not an easy thing to do, and I will just leave it at that for now. So, fitting technology into clinical practice, understanding ambulatory blood glucose reports, and using them to adjust insulin. And we'll look at some of these. So we know that this technology is underutilized in managing patients with insulin-treated diabetes because we know that both primary care and endocrine practices in the U.S. underutilize CGM and pumps in managing patients with either type 1 or type 2 diabetes when they're on insulin. Many healthcare professionals lack the confidence in prescribing and managing all of this digital technology, limited time to prescribe and manage all of this technology, and lack of online data platforms with integration into EHRs, as I mentioned. With all of that being said, all of this is getting better. As the technology gets better, it's becoming easier to do all of this. And again, as an overview, if you've been avoiding dipping your toe in the water to get into this, I don't think you can avoid that dipping of the toe much longer because patients are going to be expecting this, especially now that we have over-the-counter CGMs. Patients are going to be coming to your office and they're going to be wearing CGMs and you didn't know about it and they're going to be asking you for help. So you need to know how to interpret the CGM. A large global survey found 59% of primary care physicians and 51% of advanced practice professionals and 45% of specialty physicians cited a lack of training as a factor impeding the integration of time and range measurements from the CGM into clinical practice. And this has been the problem. Depending on when you trained and where you trained, you may not have the practical knowledge to help patients that you should. So let's just take a look at this. This is old data from my friend Steve Edelman, 2007, looking at the differences between a controlled A1C of 6% compared to what we see at 7% compared to what we see at 9%. And of course, this is a simplistic cartoon, but this gives you the message about averages. Now, what about variability? Well, this has been an interest of mine in a long time when we first started downloading glucose meters in the mid-90s. And, we see more hypoglycemia with more variability, a very controversial topic of whether or not you see more complications, more eye and kidney disease with more variability. And from a theoretical point of view, you can make the argument that there's more oxidative stress and more inflammation, but it's been hard to show this in a clinical trial. More cardiovascular complications with variability. Again, hard to show this in a clinical trial. Higher variability also is seen with mood and reducing quality of life. So what's the appropriate A1C with patient A, B, or C? A has 100% time in range, 0% time below range. Time in range is 70 to 180. Same A1C with B, but look, 8% time below range, 63% time in range. We want that number to be above 70. Same A1C of 7, but only 24% time in range, 18% time below range. This person is hypoglycemic 18% of the time. So the A1C don't really tell you the story that as the clinician and the patient needs to know. So what is a good time in range? What is good control? Well, for most people with type 2 diabetes, as I mentioned, we want that time in range to be more than 70, time below range less than 4%. I am hopeful that that 4% goes away. Every 1% is 15 minutes. And what's that saying is under 70, it's acceptable to be an hour a day or a little less than an hour a day to be under 70. I don't agree with that. And we actually have the technology now that doesn't have to happen. Less than 1%, less than 54. What about older type 2s where we're not trying for the very tight control? Well, here the most important is hypoglycemia. We want that less than 1%. We will accept time in range of 50%. Pregnancy is different. Pregnancy, we've moved the goalposts. And now the goalpost, instead of 70 to 180, it's 63 to 140. We want that greater than 70%. And then we want that 63 to 140 to be greater than 90% in pregnant women with diabetes, whether it's gestational diabetes or type 2 diabetes. So just to remember, insulin has changed quite a bit over the years with our long-acting analogs, our old NPH. You saw at the very beginning, we're not using much NPH anymore. We're mostly using these analogs. And as I also mentioned before, insulin detamir was taken off the market in the U.S. in March of 2024. So if we look at the effective basal insulin on a 24-hour profile, we have 8.1% A1C with degludec, 8.2% with glargine. You can see these curves are pretty much the same. Now, what I have to tell you, though, is these are self-monitoring of glucose levels that we're looking at here. These are just the glucose levels. As a rule of thumb, with degludec compared to glargine, both in type 2 and type 1 diabetes, even more so in type 1 diabetes, we tend to see less hypoglycemia, especially at night. Now, if we look at baseline again, self-monitoring of glucose, what we see here with these profiles of the finger sticks, now we're looking at the finger stick glucose profiles. We see the numbers pretty much on top of each other. The A1C is also very close. And the bottom line is when you're using basal insulin, you can shift the 24-hour glucose profile down, but the basal insulin is not going to do anything about the spike after eating. Nevertheless, when you look at these spikes, with the highest spike at dinner at about 1 170, 180, you're still doing pretty well, as you would expect you would do with A1Cs in that level. What about mealtime insulins? Well, we now have, when we're just looking at the insulin concentration, you look at healthy subjects over here that spike very high. None of our insulins do we get even close to that height. We have Lispro and Aspart that we've had for a long time, but now we have faster acting Lispro or Aspart and Lispro. And it is a tad faster, but we haven't been able to show big differences in clinical trials with these two faster acting insulin. And when we look at the glucose levels, again, we see the bigger postprandial spikes with the Lispro in blue, the Aspart in green. The spikes are not quite as high as what we see with the faster acting insulins, and we look at that compared to the healthy subjects in the gray. Now, is your patient in good control? Well, let's take a look. This patient has 78% time in range. Good. We want it above 70. 3% time below range. Good. We have a glucose management indicator. What is that? That's the estimated A1C. Remember I said you want to do this when somebody's diagnosed? You want to do this to see if the glucose management indicator or the estimated A1C is close to the measured A1C. That's very helpful to know if you can trust your A1C or if there's a discordant A1C for some reason. This is the ambulatory glucose profile. You can see the glucose level coming down a little bit at night. That means there may be a little bit too much basal insulin. We don't want bedtime glucose at bedtime to morning glucose when they went up. We never want that dropping more than 60 points. And ideally, we want it to drop less than 30 points. In either event, this one looks like it's going down a little bit, but it's not going down 60 points. And you can see the overall spikes with each meal. There's no real pattern here of concern. Now, if you assume this patient is using basal insulin and one glucose-lowering agent, would you make any changes to this insulin regimen? Well, it sort of depends on the patient. The GMI is 6.7. Patient is still having some hypoglycemia. You can see from the AGP, the ambulatory glucose profile, the hypoglycemia is occurring here in the middle of the night. Is there anything to do? Could you reduce the basal insulin and add another oral agent? You could. We're not told what the oral agent is. What would happen if you reduce the basal insulin and add a GLP-1 if the patient could tolerate it? There's all kinds of things you could potentially do here, but the hypoglycemia is 3%. If this is a 45-year-old woman, I'm probably not too concerned. If this is a 75-year-old woman, this is too much hypoglycemia for me, and I would cut down on the basal insulin, and I might want to work more on prandial insulin in the middle of the day. So there's lots of options with both the insulin and all of the other choices we now have available. What about this one? This is a really interesting one. Assume the patient is using basal insulin and 2 oral meds. How would you adjust this patient's insulin regimen to address the hyperglycemia without increasing hypoglycemia? Well, let's look at this. 36% time in range. That's pretty low. But look at all this hypoglycemia, and the hypoglycemia is occurring very late at night and overnight. Now, this patient is on basal insulin alone. And when I look at this and I see an estimated A1C or GMI of 8.1%, I'm thinking, wait a minute. We're doing this wrong. And what really caught my attention with this case is this glucose variability of 45.2%. Now, this is somewhat of a controversial metric, especially the target. But one thing I can tell you for sure, if you have a coefficient of variation, which is this glucose variability metric, over 40%, this patient is making very, very little insulin. This patient is severely insulin deficient. And as a matter of fact, when I see a glucose variability this high of 45%, I actually ask myself, does this patient have type 1 diabetes? Because as a rule of thumb, patients with type 2 diabetes on insulin have much lower glucose variability metrics, their coefficient of variation. In fact, it's usually less than 30. And what I'm going to do is I'm going to do a workup for type 1 diabetes because I'm not sure this patient should be on any oral medications. When I look at this, I think this patient needs basal bolus insulin, and I'm not sure any of these oral medications are doing anything because I'm wondering if this patient is even making any insulin and is just living on the basal insulin. At least that's what I think of when I see this patient. So putting this together, you want to have the patient engaged. You can see how much they're wearing their CGM, in this case, 99.9%. The variability target is generally above 36. I don't agree with that because this coefficient of variation is also based on what the mean is at the time. But this is indeed the ADA recommendation of below 36 is you want it below 36. You can look at the whole profile from the AGP. And then if you're looking at specific days, you can go down and look and see what's happened on the specific days. So in this example, time above range is quite high, 43. Time in range is not in target. Time below range is scary at 10% when the target is less than 4%. You can see the highs and the lows. What's clearly happening here is the patient is giving their insulin late. And they're often giving it when it peaks. You can really help the patient if they can't remember to give their insulin by taking that alarm down. Now, this is using millimolar. 10 millimolar is 180. But if you bring the alarm down to 220 or 200, and the patient hears the alarm, that will hopefully get the insulin in faster and hopefully not so much insulin that they're getting hypoglycemic. But you can see everything from this kind of data. So fitting diabetes technology into everyday living, matching these needs of our patients with the right combinations of technology. So here's a case study of a 54-year-old field engineer who travels extensively by car, newly initiating basal insulin. Avoiding hypoglycemia is a very high priority. Current medications include, you can see, metformin, the SGLT2 inhibitor, dapagliflozin, and the GLP-1 receptor agonist dulaglutide. A1C is 8.1, and his fingerstick data shows his blood sugar is 110. And so the question is, what are the goals? What insulin delivery technologies will you discuss with him? What glucose monitoring technologies will you discuss with him? And this is something that is really shared decision-making in somebody with an A1C of 8.1%. This is the perfect time to start basal insulin. Most of the commercial payers and Medicare will cover CGM for this specific patient to hopefully alleviate his fears of hypoglycemia. And especially with someone who's very fearful of hypoglycemia, you can turn the alarm up, not volume-wise, but glucose-wise. So set that alarm at 80, set that alarm at 85 or 90 for people who are very concerned about it. And then as time goes on, you can move the alarm to a lower glucose level. This is a 57-year-old librarian who worries about complications of her diabetes and frequently over-administers bolus doses. Her A1C is 6.7. Her CGM download reveals frequent mid-afternoon hypoglycemia. She's had 2 episodes of severe hypoglycemia at work requiring coworker intervention. And she's on metformin, degludec, and fast-acting aspart with each meal. So what insulin delivery technology will you discuss, and what glucose monitoring technology would you discuss? Well, this is another one. Now, this is more like what we see in type 1 diabetes, but it does happen in type 2. And as I said earlier, I think this is going to happen even more commonly in type 2 in the future with our young people as they get older and they become more beta cell deficient. But this is clearly somebody I would want to put on an automated insulin delivery system for the same reasons that we do in type 1 diabetes, because the hypoglycemia is simply unacceptable. Okay, now we're going to talk about a 47-year-old woman retail store clerk who has previously stopped her insulin therapy because she felt the carb counting was just too overwhelming. And we've all seen patients who were not mathematically inclined to do this. She's now on metformin, but her A1C is quite high, north of 11%. She's symptomatic. And unfortunately, she's on a high deductible health plan, and that often dictates what we want to do with our therapy. So the question is carb counting required with basal insulin therapy? What insulin delivery technologies will you discuss with her? What glucose monitoring technologies will you discuss with her? Well, let's start with the last one first, because if she is going to need insulin, which she does, CGM is always appropriate. Again, she's on this high deductible plan. That may not be possible, but that's at least what I'm going to strongly suggest. Now, as far as does she have to carb count and does she need to go back on insulin? Well, there are a couple of ways to answer that. One way is that pretty much anybody with a double-digit A1C, they need insulin therapy most of the time. And there are really two options as I see it. One option, we're not told if she is overweight or obese, but we know she has type 2 diabetes. One option is to give her basal insulin and a GLP-1 receptor agonist, and actually doing that in a combination mixture. So there's Iglar-Lixi and Ideglira. There are two of them on the market, and both of them would be appropriate. The problem is that for some people, either doing the mixture of the basal insulin and the GLP-1 or doing them separately is just not possible because of price. And that's the situation here. So the other option would be to start basal insulin, but with an A1C this high, she clearly needs prandial insulin. And in that situation, I would do what we talked about before and use a connected pen. Now, I would probably say the vast majority of our patients with type 2 diabetes do not like carbohydrate counting. And in fact, there was a study quite a few years ago by my colleague, Rich Bergenstahl, who showed that in type 2 diabetes, you don't really even need to do carbohydrate counting. And one option would be to use one of the connected pens, where with the pen, you can switch it to carbohydrate estimation, and you can just do small, medium, and large and use that in the app. Or what you can even do in the app is just have a single dose for each meal, a single dose of the rapid-acting analog. And when the insulin is given, there's a Bluetooth device with the InPen or the cap with the tempo, for example, that captures the exact dose of insulin that was given. But this way they would get basal bolus insulin. Both the provider and the patient can look at the data much better than what we did with the logbook before. And we can definitely get the A1C down and the blood sugars under much better control doing it that way. What about a 60-year-old man who wants to think about diabetes management as little as possible? He's a mechanic, and we all have patients like this. They don't want to be bothered by it. He's on all this medicine. He's on 3 oral agents. He's tried 2 different GLP-1 receptor agonists, but side effects were intolerable. A1C is 8.1. Finger stick glucose shows his lowest blood sugar is 110. What insulin delivery technology will you discuss? What glucose monitoring technologies will you discuss? I'll tell you what I would do with him if he came in with this. I would probably put him on an automated insulin delivery system, especially if the insurance would pay for it. The insurances are generally paying for the pharmacy benefit. And in those areas of the country, like where I live, where the insurances are not paying for it, I think they will be, especially with this brand new FDA labeling for the Omnipod 5, and then more over the next year or two as more of them go to the FDA for that labeling. But this would be a patient that I would put on automated insulin delivery with the CGM and the pump. And then the last patient is a 78-year-old retiree using multiple daily injections. She forgets to give her insulin. Now, I can tell you, you don't have to be 78. We see this in our 18-year-olds. But her current A1C is 8.9. Her CGM shows frequent mid-afternoon and evening spikes because she's missing her insulin. And her meds include metformin, glargine, and mealtime Lispro. So what insulin delivery technologies will you discuss with your retiree? And what glucose monitoring technologies will you discuss? This is a tough one. And what I would do here is I would do 2 things. For the insulin delivery technology, I would use a connected pen so I can see when the insulin is given. And it's not so important that I, as the clinician, can see it, but that the patient can see it. And specifically, if that glucose level is starting to spike up, it's now 190, 210, 230, and the patient doesn't remember if they gave their insulin or not, well, they can just look at the app on their phone and they can see that the insulin was or wasn't given. Very helpful for patients who can't remember that. And of course, doing this with the CGM. As I said before, everybody on insulin should be on a CGM, and I would put that CGM high alert at a level that would benefit the patient. Now, with an A1C of 8.9, I probably wouldn't start at a 200 or a 220 high alert, but I might want to start at 240 or 260 or even 280, because if that 78-year-old patient can realize when that alert goes off, I'm high, and I probably died because I missed my insulin, they can then go and look and see if that insulin was given or not. And my final comment is this is also helpful for patients who need caregivers, and the caregiver can see if the insulin is given or not in this situation. So bottom line on this one, CGM with a connected pen. So the key takeaways, diabetes technology is increasingly being made available to people with type 2 diabetes, used judiciously. Continuous glucose monitoring, connected pens, pumps, apps, and data sharing tools can simplify insulin therapy and or increase self-management confidence. Support resources for people with type 2 diabetes and healthcare professionals are available, and you and your healthcare team can help insulin-treated people with type 2 diabetes find a new normal that works for them and for you. That concludes our presentation for today. I hope you find the activity informative and useful to your practice. And before we go, I just want to alert you to some useful downloadable practice aids that are included with this activity. Just click on the menu at the left. And thank you again so much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novo Nordisk Inc. To access all materials for this activity, visit peerview.com/UHT860.